Hello and welcome to today's webinar, Putting Social Determinants of Health Insights into Action. Thank you for attending, and a special thank you to our panelists for participating in today's event. We understand that your time is valuable, and we're glad to have you with us. Before we begin, I'd like to go over a few housekeeping items. At the bottom of your screen are multiple application widgets you can use. All the widgets are resizable and movable, so feel free to move them around to get the most out of your desktop space. You can expand your slide area or maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the webcast, you can submit them through the Q&A widget. We will try to answer these during the webcast, but if a fuller answer is needed or we run out of time, it will be answered later via email. Please know we do capture all questions. Additional materials are available in the Resource Center. We encourage you to download any resources or links that you may find useful. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. Webinars are bandwidth intensive, so closing any unnecessary browser tabs will help conserve your bandwidth. The webcast is being streamed to your computer, so there is no dial-in number. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters. Some networks cause slides to advance more slowly than others, so logging off your VPN is recommended. If your slides are behind, pushing F5 on your keyboard will refresh the page. You can find additional answers to some common technical issues located in the Help widget at the bottom of your screen or the Troubleshooting Guide in the Resource Center. An on-demand version of the webcast will be available and sent to your inbox approximately 24 hours after the live event. And now I'd like to introduce myself. My name is April Hollis, and I will be moderating today's event. I'm the Healthcare and Life Sciences Editor at SmartBrief. I edit newsletters that cover health insurance, medical, and life sciences topics for our professional audiences. We have a great conversation planned for today, so let's go ahead and get started. In today's webinar, we will discuss why the COVID-19 pandemic is rendering the traditional way of collecting and using social determinants of health data obsolete, how artificial intelligence is enabling payers and providers to overcome the shortcomings of traditional predictive analytics, areas of prescription medication use and disease management where AI can help move the needle on both improved outcomes and lower costs, an AI approach that enables payers and providers to become more proactive earlier on social determinants of health signals, and success in action and steps to take now to develop your own success story. But first, let's meet our panelists. On our panel today, we have Holly Miller, as the Senior Director of Clinical Products and Strategy at EnvisonRx, soon to be Elixir Options. Holly has over 20 years of experience in various aspects of the pharmacy industry. She previously practiced as a clinician, providing disease state management in the practice settings of primary care, geriatrics, and population health. She also has experience working for large health plans. In her current role, Holly directs daily operations in the Care Navigator Center for Medication Therapy Management, Diabetes, Pain, and Medication Adherence programs. Holly works closely and collaborates with sales, marketing, and operations to ensure clinical programs are meeting PBM client needs and expectations. She plays a role in the development of future clinical programs such as drug pipeline, specialty, and START solutions. Also joining us is John Chowalter, MD, Chief Product Officer at Javion. John brings visionary thought leadership on the application of advanced information technology to improving outcomes for patients. His unique education in biomedical engineering, physiology, clinical informatics, and internal medicine has allowed him to work at the intersection of those fields to positively impact patient care and health system efficiency. His work has been recognized with cross-industry awards, including Computerworld's Premier 100 IT Leaders and Health IT Awards, such as the Chime Collaboration Award. Dr. Showalter is dedicated to using his passion and knowledge to ensure that Javion's machine has the maximum positive impact for patients. We also have with us John Fraunfelter, MD, Javion's Chief Medical Information Officer. John is an internist and physician executive in health information technology and is currently leading Javion's clinical strategy. With over 15 years leadership experience, he has a broad range of expertise in systems management, care transformation, and health information systems. Dr. Fraunfelter has held a number of medical and medical informatics leadership positions over nearly 2 decades, highlighted by his role as Chief Medical Information Officer for Inpatient Services at Henry Ford Health System and Chief Medical Information Officer for Unity Point Health, where he led clinical IT strategy and launched the analytics programs. Since 2015, Dr. Fraunfelter has been bringing his expertise to healthcare through health IT advising to both industry and health systems. His work with Javion has enhanced their clinical offerings and their implementation effectiveness. Dr. Fraunfelter has also held professorships at the St. George's University and Wayne State Schools of Medicine and the University of Detroit Mercy Physician Assistant School. Dr. Fraunfelter received his MD from Wayne State University School of Medicine. Thank you so much for joining us, Holly, John, and John. I'd like to start our conversation today by asking Holly how EnvisonRx Options has traditionally used social determinants of health and predictive analytics to serve clients and members.
Great. Thanks so much, April, for asking. So at Envision, our care navigators have historically utilized a series of barrier questionnaires, or otherwise known as assessments, to utilize and determine a patient's social determinants of health. This is sometimes seen in practice where they may ask a patient, tell me about how you do such and such, or tell me about how you do XYZ. We've also obtained risk scores based on predictive analytic models. Then, as our clinicians are talking to the patients on the phone or seeing patients face-to-face, they try to mesh those various pieces of data together during the patient appointment through motivational interviewing and assist the patient to make those behavior changes.
Thanks, Holly. Can you talk a little about the shortcomings of predictive analytics, particularly when it comes to social determinants of health signals and data? I'd like to ask John Chowalter and John whenever you're done, I'd like to ask John Chowalter and John Fraunfelter to weigh in on this as well, but let's start with you, Holly.
Sure, no problem. In the model that I described above, it really does take a lot of time, and it is very challenging for the clinician because they're usually working with the patient right there and then, and they're trying to grab not only the data that's at their fingertips along with the information that the patient is telling them right there and then, and track the various pieces to put together the facts, identify the issues, also kind of pull up those key words or the things that the patient is saying to identify those issues where you might want to pull out transportation issues, housing issues, food issues, and then still find those key words and then assist the patient to provide a solution because that's why they came to see you or call you that day.
Okay, and John Chowalter, what else can you tell us about the limitations of predictive analytics?
So one of the difficulties with predictive analytics is that they frequently are based on non-modifiable factors. Even when the prediction is accurate, it's not actionable, that it's not based upon something that you can then intervene and do something positive for the patient. So as Holly said, you then fall back on screening questions and long list of questions, listening very carefully for key words, and an open-ended interview that can take a long time and feel kind of uncomfortable to the patient as you just keep digging and digging, trying to connect the dots. And they focused on, making an accurate prediction and identifying those that are at the highest risk, but not really a focus on, can I do anything to help that individual?
Okay, thanks. And John Fraunfelter, what are your thoughts on these shortcomings?
Yeah, a couple other thoughts. Thank you. Predictive analytics requires data. It doesn't really have the ability to infer what it doesn't know. So we have the garbage in, garbage out problem. As a result, Holly described the burden of manually collecting that data. So that's one of the first problems, is you're limited in predictive analytics by having a trust in the data. And there's a fundamental trust problem, whether it's understanding socioeconomic data about individuals or even clinical data. Just ask a clinician when they're looking in the chart about discrepancies in the chart. The second thing I'd like to point out is that knowing something to be true about a patient doesn't equate with risk. Predictive algorithms do not take that into account. They're fixed and using weighted scores for variables to come to some conclusion. And they're right oftentimes. You can tune that predictive model to be really good for certain outcomes, but that's where it stops. With machine learning, with artificial intelligence, we can interpret more deeply which facts are actually risk factors. And so just because 3 people in the same apartment building live in a food desert doesn't mean they're all equally at risk for nutritional deficiencies. It takes a lot more sophistication in predictive modeling to get to that level of detail that actually has any value for the patient.
Okay. I'd like to talk a little bit about how the pandemic has amplified these shortcomings. John Felter, let's start with you, and then after that, John Chowalter, if you can jump in, that'd be great.
Yeah, well, springboarding off that previous comment, predictive models also assume that the base population upon which that model was developed hasn't changed. And if anything is true in this pandemic, is that the base population is fundamentally different. We have a significant disruption around socioeconomic factors in particular. Predictive model doesn't take into account that a cohort of patients lost their employment, for example, and the payer mix is shifting at a population level, but for individuals, they lost their job, they can't afford insurance, and on and on. Transportation is different, everything has changed. The predictive models do not take that into account at all. That's a significant shortcoming.
Yeah,
and John Chowalter.
Yeah, Dr. Crowder, I think that's a great point. The predictive models assume a standard starting point. We've used them in healthcare for a while, but whether you're looking at the cardiovascular predictions that came out of the Framingham study or at, Braden scores, they don't perform the same on every population, and they perform best on a very similar population to what they were used to develop. So when you have a seismic shift, like a pandemic, and struggles with the economy and struggles with insurance, the models that were based upon a steady state no longer hold their validity, and you don't know what the impact to their accuracy is until you've already acted on them, until months have gone by. So there is a delayed understanding of when predictions drift with predictive modeling, and we tend to treat them very static and use them for years. So Braden, that's used on the inpatient side to predict, who's going to develop pressure injuries, bed sores, it's the same model that we've used for the last 25 years. And the population today is not the same as it was 25 years ago. And when you look at predictions around social determinants of health, when there is a major shift in the baseline meaning of what it means to live in this community or that community or have job X, Y, or Z, they just don't hold up, and they aren't designed to continue to learn and adapt.
That's really interesting. Thanks to you both. And now, audience members, we'd like to hear from you with this poll question. What is your biggest concern about the COVID-19 pandemic and your most vulnerable patient members? Medication adherence, future impact of deferred care, opioid misuse, or all of the above? And while we're giving the audience a few minutes to log their answers, Holly, what area do you see as most critical?
Sure. So having a passion for medication adherence, I would have originally started with that, but I'm very interested to see what the audience thinks and really what that future data is going to show. When this all started, and we were very concerned at the PBM, what about medication adherence and what are we going to do during these weeks and then months of lockdown? So really, I have to give a shout out to the PBM industry, the pharmacy, the healthcare industry. Everyone did a fantastic job allowing patients to get early refills and really rallying to make sure that patients could get their refills. Prescribers were still making sure that if people didn't have refills, they were faxing those back into the pharmacy. And we actually have seen medication adherence rates actually higher than they typically are at this time of year. So that's good news. Now we have to just make sure that patients continue to take them while they have the medications on hand over the next few months. So, now looking at the other two areas that you mentioned, future impact to deferred care, I really think that that's an area that we're going to see in weeks and months and years to come. Just anybody you come in contact with, everything is deferred. Dentist appointments, just every regular care thing that people had has been deferred. And then getting in for those appointments is such a different experience now. So I really think that that's something that we're going to see really play into it. And then opioid misuse, a huge part of the work that my team does is related to pain management. And that epidemic obviously was prior to this pandemic, and was one of the things that we were very focused on at Envision. And I think that is definitely something where people are in lockdown and they are already have depression, and now you add chronic illness, aloneness, all those things that contribute to possible use of opioids or any dependency. And I really think that substance abuse as a category is something that we're already seeing spikes in. So what did the audience say?
Let's take a look at those results. So it looks like the biggest concern is future impact of deferred care, followed by all of the above. So the future impact of deferred care, 47.8% selected that, and then all of the above, 43.5% have that as their biggest concern, followed by medication adherence at 8.7%.
Yep, definitely a mixed bag for sure. And I think all those categories, as we've said, are just all of the above.
Yeah. Well, Holly, I know that there's also some problems with motivational interviewing and that it can feel like an interrogation. So how can AI help maximize motivational interviewing and address these problems?
Sure. So one of the things that we are seeing, and it's really been exciting as we are utilizing the clinical AI, it's allowing our Care Navigator team to be more prepared to speak with the patient during their appointments. They really are having the clinical risk factors, the socioeconomic risk factors, and the prioritized recommendations right at their fingertips. They don't have to make assumptions. The clinicians are prepared. The patients are engaged. The patients feel that we already know them. Long times ago, or maybe not all that long ago, you had the community doctor that knew you as you came along. But now there's a lot of different things in healthcare, and you don't always get the same practitioner. And in our call center, you don't always get the same care navigator. But using the AI where the information, again, is right at their fingertips and it gives the most information, like I said, about their clinical risk factors, or information to say, this patient most likely has transportation issue. This patient most likely lives alone. They may have a clinical risk factor that they didn't have last month when we talked to them, but the AI pops it up. The patients feel very engaged, and it lets us make a solution and a recommendation to them much sooner than we would have in the past, is what our Care Navigator team is saying. And then we're not also spending 10 minutes going through a patient assessment or barrier assessment. We are already, within that first 10 minutes, giving the patient solutions. So again, I think, there's all kinds of studies out there to say that patients or people in general lose attention after, just a few minutes of talking to them. And if they've already lost that attention when we're doing a barrier assessment, we'll never get them to put a solution in place. So once we have them engaged, they're much more apt to put in those motivational interviewing solutions and be engaged for their individual targeted needs.
These sound like some very important improvements. John Chowalter, what would you say is the additional value that AI can bring?
Yeah, so I think one of the main things Holly brought forward is, as a primary care physician, the patients hated nothing more than they filled out a questionnaire, the nurses asked them a questionnaire, then I came in and asked them the same questions because they felt like we weren't communicating, we didn't know them, and then you had to spend that time, rebuilding the rapport to get them to the place that they would engage or activate. The ability to holistically understand an individual, to have a electronic representation or a phenotype that you can bring in front of a clinician, bring in front of a care navigator, and give them sort of a heads-up display so that they can mentally prep, understand where they're going, have a hypothesis of what their plan of care is going to be before they ever even pick up the telephone. Just allows everyone to solution at a deeper level and really get the members and the patients to take the actions that they need to take to have better self-care or bring the resources that they need in order to help them care for themselves.
Okay, thanks. And John Fraunfelter, what are your thoughts on these shortcomings and the additional value that AI can bring?
Yeah, and Holly touched on this. The process of collecting that information is challenging. One of our customers, a health system provider, but their social workers, they estimate, spend 50% of their time simply interviewing patients and collecting data. So AI can augment their efficiency. It can bring sharper focus, allow them to do some targeted interviewing, and it increases their capacity essentially. So that's one of the first points, is that bringing that sharper focus, it essentially increases their capacity and can decrease the time spent just collecting data, which is functioning way below the level of a licensed provider such as a social worker. The second point is that if you take these standard interviewing questions and a list of questions that I've got to get through in talking to a patient, they don't adapt to the patient's situation as well as machine learning can. And I want to emphasize can. It really depends on how it's done. So I want to give an illustration. But machine learning, artificial intelligence can recognize, for example, that a patient is isolating and their risk is increasing, say, for depression. We've got oncology solutions where and in the oncology practices, they screen for depression regularly, and they know their patients very well. And yet when we identify somebody at risk for depression, they dig a little deeper, such that over a 6-month period, we've increased the appropriate treatment of depression by 33%. And if the data wasn't there, I never would have believed it myself. But the point is, standardized care processes and questionnaires, you fall into a lull and a false sense of security and accuracy that you're collecting the right information and that it's accurate and complete. And it just isn't true.
Okay, thanks everyone. Holly, in your work at a TBM seeking to apply AI to put social determinants of health insights into action, what areas of medication management are you primarily focusing on?
Sure. So we're working medication adherence, as I mentioned earlier. We are looking at all of the HEDIS or PQA adherence measures, but really looking to focus on those big three, along with diabetes is very important, along with opioids.
Great. So I'd like to ask you to talk a little bit about which areas are most essential and why as far as medication adherence.
Sure. So like I mentioned, those big three is what we call them. So diabetes, blood pressure control, and cholesterol. They really are the top, some of the top chronic primary care conditions. They are extremely costly, and they are, for us at the PBM level, they're recognized by CMS as STAR measures. And for our plans, that has huge success or non-success, depending on how they fall in the STAR measure ratings. So that's very important to a lot of our clients. And outside of meeting metrics, again, they just are such important chronic conditions. And really, if you can get the cholesterol and the blood pressure control, the diabetes usually comes after. So those are the three areas that we're focused on first, and then we'll hit the other, like I said, PQA and HEDIS-driven ones.
Okay. And diabetes medication management has long been a critical area of focus. Why is it becoming even more important?
Sure. So as the prevalence of type 2 diabetes continues to rise, this continues to be, again, as the nation's important chronic disease. And again, one of our clients' top 5 areas of spend. And this is really due to more and more medications being approved within this space. And also these treatments are being approved within the treatment guidelines. In the past, there may be drug approvals, but they weren't preferred or they weren't recommended within the treatment guidelines. Now we're having novel medications come out, and they are recommended within the treatment guidelines. So this just continues to be an area of need. Like I said, especially, and even during pandemic times, I think, we haven't been able to go out and exercise. We haven't been able to get as much fresh food. So it will also be interesting to see the rate of type 2 diabetes after or during this pandemic and see what that has done to that rate.
Yeah, that's true. We probably will see an impact from those things. It's interesting to see what happens. We're all familiar also with the opioid pandemic. Why in the midst of, with the opioid epidemic, why in the midst of a pandemic is it even more urgent to address this persistent and devastating problem?
Sure. So again, like we said, prior to this pandemic, this was one of our hot topics or really epidemics that we were focused on. And really anxiety, grief, isolation, financial worries, changes at home and work, and ongoing sense of uncertainty during these times are all really threatening people, and substance abuse and use disorders are really a huge risk. Opioid use is something that people can get their hands on. People have it from leftover surgeries. People have it from grandma and grandpa. You can get it. It's very accessible. So that is definitely a key area of focus. And just those are just some of the highlights, but a lot of that information is starting to come out, and we're starting to see a lot of that trend.
Okay, thank you. And John Chowalter, can you explain how social determinants of health and AI work in each of these areas, starting with medication adherence?
Certainly. So one of the things to understand about artificial intelligence and social determinants of health and lifestyle, how much you exercise, how social you are, what your digital fluency is, they all interact with each other. There's no individual standpoint. So living in a food desert but having a high income and having good transportation is not the same as living in a food desert with no transportation and a low income. So the social determinants of health all interact with each other and create a environmental and behavioral risk profile for an individual. And they cause markedly different interactions, whether you have high challenges with social determinants of health or low challenges with social determinants of health. Those with high challenges, those that have health literacy issues, access issues, on medication adherence, it may be a matter of, not completely understanding when to take their medications, how to take their medications, reinforcement and coaching, about how to, count carbs or correctly use your insulin, or for COPD patients, how to correctly their inhalers. Whereas others that have financial difficulties, large families, potentially large families that also have chronic illnesses, they may be in a position where they're choosing between purchasing their medication and their child's medication. And if you're a parent trying to decide between purchasing your diabetes medication or your children's asthma inhaler, you're probably going to buy your child's asthma inhaler and forgo your own medication adherence if you're forced to make that choice. So understanding the likelihood that people are facing those hard choices, understanding the likelihood that they may not know how to take their medications, or that they may not have the support that they need. If you've got a elderly individual that has some mild dementia and is totally safe to stay at home and is able to take care of themselves, but is supposed to remember to take a pill 3 times a day, that becomes much more complicated for that individual, and how do you support them? So understanding how the social economic also plays into their clinical feature to understand where to mitigate the risk really becomes important. And for general medication adherence, most of those medications are treating conditions that we don't really feel. We don't really feel hypertension. We don't really feel diabetes unless it's really bad. Those medications are frequently put on a lower priority compared to something like a COPD inhaler, where if I don't take my inhaler, I have trouble breathing, or if I don't take my anti-epileptic medication, I risk having a seizure. Those kind of choices really affect medication adherence. When you get into something like opioid misuse, then you get into a lot of, as Holly was describing, behavioral health concerns, social isolation, chronic pain management, depression, that are all made worse by social economic determinants. There's even literature on long commutes are associated with higher levels of higher rates of depression, higher rates of suicide. So understanding at a granular level how people are living can really help us understand how to overcome their difficulties with their medication or their care in general.
Okay, thanks. Are there any more specifics that you can add about sort of the intersection of social determinants of health and AI for diabetes in particular?
Yeah, so diabetes in particular is actually one of the areas that choices are definitely being made. There's good literature about it, and it definitely comes up in AI as identifying those individuals where the social determinants of health and the support aspect really has them in a choice of choosing between one of their medications and a diabetes medication, especially for the type 2 non-insulin dependent diabetics. So the insulin-dependent diabetics much more likely to be checking their glucose, and a understanding of where their blood sugar is. As a type 2 diabetic not on insulin may only have their glucose checked when they see their doctor, may only get their hemoglobin A1C checked every 3 months. And they're comparing that against medication for their children, their pain medication, their inhaler. And for diabetes in particular, the substitution choice is a very real risk factor that we're seeing coming up in AI a lot more often than we really saw it coming up in clinical practice from the way that I was educated. It is very much supported by the literature, but it's one of those things that AI is bringing to the surface as identifying it's much more common than we really thought it was.
And finally, can you talk a little bit more about opioid abuse and pain management?
Sure. The opioid misuse, the way that it is structured today is very much after the fact. It's the flags are frequently set at six or seven different prescribers, or more than 200 days supply and 180 days supplies. Those factors are associated with increased deaths from accidental overdoses, from increased hospitalizations and ER visits from overdoses, and increased side effects, but they're all identified after the fact. With AI, we're able to identify those people that are on trajectory towards doing that after the second prescription. So, they get a prescription from the second doc. We're able to understand this person is very much on a trajectory to knowing to opioid misuse. And that takes looking at both their socioeconomic determinants as well as an understanding of who's prescribing those medications. A opioid prescription from an oncologist and an opioid prescription from a palliative care doc are different than two opioid prescriptions from two different ER docs. So an understanding of how the social determinants of health are interacting with what medications are prescribed as well as who is prescribing them really lets us understand who's on a bad track, and intervening after the second or third prescription from a different doc has a much greater chance of preventing the downline hospitalization or, unfortunately, the downline overdose resulting in death. And the current way of doing it is very much we act after there has been a sufficient amount of misuse as opposed to an indicator of future misuse.
All right, thank you. Now I'd like to talk a little about improving outcomes and overall costs. Holly, can you tell us about how these new approaches enable PBMs like yours to help their clients and their members attain improved outcomes?
Sure. So in the past, we have wasted so much time and, frankly, money trying to reach members who will never respond to us. The number of patients is just overwhelming that we needed to reach, and frankly, we were just not able to reach them all. So we really needed a solution to help us prioritize which members were most likely to respond to our outreaches, and it was key to our success. And like I said, within those three buckets of work for adherence, diabetes, and opioids, as our client sizes grew, we knew that this was just an area that if we did not start to tackle this, we were not going to be successful in meeting the metrics that our clients needed to be hold us accountable to, and that their patients we needed to find ways to reach them. So knowing how the members wanted to be communicated with, or meeting the member where they want to be treated is really how I like to say it. So the AI really, one of my favorite things is that it really provides the mode of communication that the member is most likely to respond to. So for an example, if Mrs. Ferguson wants to be sent digital outreach, the AI tells us that. Or if Mr. Poor wants telephonic care, we know that. If Mrs. Patel wants her follow-up care plan mailed to her, we know that. So we have all that data right at our fingertips, again, to make the most meaningful intervention. And that's really, really helping us improve our outcomes and meeting the member where they're at, and risk stratifying who is never going to talk to us and who is really going to most likely respond in any of those different modes of communication.
And what about the long-term impact on cost? It looks like an upfront investment in an AI tool can save money over time.
Yeah, Exactly. And like I said, we have all kinds of data to show all kinds of interventions and hours spent on not reaching patients. And we're very excited to see the needle move on increased engagement rates, and even on calling patients, if it normally took calling them 6 times to get them to start adhering to a medication, or maybe agreeing to get their A1C checked. Again, now we're connecting with them in the first or second call, and there's cost savings right there because we're getting them interventions sooner, because we're making those connections sooner.
Thanks, Holly. Let's hear from our audience again with this poll question. What area does your organization need the most help with? Risk stratification, knowing what to do with high-risk individuals, improving communication response, or all of the above? And while everyone logs their answers, John Chowalter, what are you hearing in this regard?
So we definitely are hearing about all 3, but I'd say the thing we are most commonly hearing is knowing what to do with the high-risk individuals. Again, a number of our clients have already had predictive analytics and, to some extent are doing some risk stratifying and cohorting, but it doesn't really help them know what to do with that group. They may be identifying just a group that is non-responsive or non-adherent, and really having to put much more effort in moving the needle than would be possible, or maybe it's a group that really just is going to respond to a mail outreach, and you could focus your outreach efforts on someone that wants to be called. But we're hearing the most about how do I get the next right step, what's the next right step, and then how do I get that engagement and activation to get it done. But we certainly have had conversations about all 3.
All right, well, let's see what the audience said. And it looks like knowing what to do with high-risk individuals is a top concern, 33.3%. Also all of the above, 33.3%, followed by both risk stratification and improving communication response got 16.7% each. So interesting spread. Well now, John and John, I'm hoping you both can amplify the points Holly is making about improved outcomes and long-term cost effectiveness. I'd like you to tell me a little about how marrying AI and social determinants of health can help organizations like EnvisonRx options and health insurance providers transition to a more proactive model. John Sonnfelter, let's start with you.
Yeah, so we've covered a lot of this ground already. Holly has demonstrated great illustrations and successes there. What I think is happening, if we sum it up, though, is I'm from the north. I'm from Michigan, and in a sledding hill, it's easier to stop the sled near the top of the hill than when it's halfway down. When patients are in a decline, preventing that decline when they're already in that point of acceleration is really difficult. We're moving further upstream with these insights that are both socioeconomic factors as well as clinical factors to help address those individual patients sooner and prevent them when they're still on that safe part of the slope before they started to deteriorate. This is so much so that we run into a bit of a new problem. It's how do you measure what didn't happen? And so measuring success based upon events that didn't occur is an interesting question, and we're also demonstrating some measurements against base populations or cohorts in matched control analyses to demonstrate this. So we're seeing success there, and it's through many of the techniques and points that Holly did make.
Okay, great. And John Chowalter, did you want to add anything?
Yeah, so one of the areas that there's just a reality of healthcare is that we can't do everything for everybody, and everyone doesn't need everything. So I mean, I don't know what the exact percentages are, but we land on a kind of 80-20 rule, right? So we do the 20% or the 30% that covers the 80%. but it doesn't help with the other 20%, and we don't really have good insight into what that other 20% is. And even for that other 20%, we can't do everything. But when we know that you're in that 20%, you're in the group that needs more from a social terms of health standpoint, and we know which aspect you're struggling with the most, or the short list of things that you're struggling with the most, then we can do that extra. It can get fit in. It can be done with efficiency. It can actually, as Holly pointed out, get things done and engage quicker so that you can do more things for more people. So there's a matching of social determinant risk and identifying that smaller group of patients that is at increased risk, understanding what's driving their risk, and giving that to clinicians to augment their actions and their care plan really does drive things forward, whether that's giving it to a navigator or a case manager that is calling the patient, or identifying them as higher risk when they call into a call center. So during the COVID-19 pandemic, we had identified individuals that were at increased risk due to their social determinants of health, and that was inside the health system's call center. They'd call in, there was a flag there that said, this is one of those high-risk patients in that 20%, and they got put onto a more intensive care plan, a more intensive follow-up in order to make sure that they were treated appropriately to actually meet their needs, because they weren't going to be covered by the, quote, standard protocol. So augmenting that ability of clinicians to make a good care plan with a knowledge that this person I have to put the extra time and planning into, because there are more barriers to overcome, can really accelerate the proactive and preventative process of medicine.
Okay, thanks. And staying with you, Dr. Showalter, can you also talk about other medication-related areas where AI can prove useful?
Sure. So, in the area of medication, an understanding of who's at risk for specialty medication, non-compliance, understanding patients who are at greatest risk for side effects in order to be able to screen for those side effects, especially if they're red flag type side effects, and understanding how the social support or family dynamics around a patient really affect their ability to stick to a medication regimen are very important. The other layer that we find to be very important is the clinical aspect, when there is something like rheumatoid arthritis that may be affecting their ability to use an inhaler, or even potentially open their pill boxes. It has the ability to identify occupational therapy or home health aides or nurses to help those patients who want to be compliant but actually have a clinical or physical barrier to making that happen.
Okay, thanks. And Dr. Fraunfelter, can you talk a little bit about some clinical areas beyond medication management?
Yeah, we're seeing a tremendous growth in this space, not only within our offerings, but also in general in healthcare. So think of any of the traditional clinical conditions and where focus is to reduce complications there. So cardiovascular diseases, pulmonary diseases. You can see on the slide here, behavioral health, chronic disease management is essentially what I touched on. So that's a whole body. But then if you think of things that are just almost like a mind bender, what about preventing conditions that aren't typically thought of as preventable, like sepsis that occurs in the community setting? Of all the patients that end up in the hospital with sepsis, 75% of them have it when they come in the hospital. And the ability to identify those patients at risk and prevent them so that it never happens is where AI can play. Another example that is something you wouldn't think of out of the box would be identifying patients with conditions that haven't yet been diagnosed. So especially in the time of the pandemic, identifying patients who are delaying or deferring their care and they're more at risk for cancer. And we're even seeing the literature start to show that the delays in diagnosing cancer are creating a wave of patients with more advanced cancer when they're diagnosed. But the ability to identify those patients that should be proactively screened is another example where AI can have a benefit even in the setting of this pandemic. So in the end, it's almost a question of where AI cannot add value in the clinical space, and where standard processes are important and best to put in place. Let's say checking a box to make sure that cigarette smoking was addressed and that sort of thing. You probably don't need artificial intelligence to make sure you check your boxes. But when it's about the patients that are either with unrecognized risk or where surprising harm is occurring, those are the places where AI can thrive, where we've really struggled to understand what's happening to the patients to this date.
Great, thank you. And you touched on this a little already, but I'm sure our audience would like to hear some specific examples of these successes in action. If you guys could explain how Javion's AI tool enables payers and providers to put social determinants of health insights into action, and tell us about some of the successes you're seeing. John Fonfelter, let's start with you.
Yeah, again, I'll give a patient example here. I think it's really compelling. There's a patient admitted to the hospital with a clot in their leg, a deep venous thrombosis. We identified that patient at risk for readmission, and the reasons were socioeconomic factors. He had a risk around transportation and ability to afford his medications. And that patient was overlooked by the case managers, unfortunately. The patient did follow up with his primary care doctor, but he came in late and almost missed the appointment. So his primary care doctor was inquiring why, and he said, "I'm really sorry. I had to take a taxi because we only have one car, and my wife has the car for her work today." So he did have a transportation challenge, and when she asked him further about his medications, he said he hadn't filled it yet because he couldn't afford to fill the script. And that's a patient that could have been given vouchers or something on the way out the door, followed up more closely, and he was a readmission just waiting to happen, except he fortunately made it into his doctor's visit in time. So that's where social determinants come into play, and they really are drivers of health outcomes. We've only recognized this in the last 5 to 10 years, but they are very impactful.
And John Chowalter, what are you seeing?
Yeah, and so I mean that's a great example, John. That patient was one taxi ride away from being a readmission. What we see is when we bring AI in to augment people that are already trying really hard. So if you're looking at transitions care management programs, chronic care management programs, oncology care management programs, where people are already really invested and driving care and doing case management, the AI augmentation, the insights, that power to have a better conversation, know what to do, really matters. So, we've seen results as high as $750 per member per month for transitional care management improvements, $300 for chronic care management improvements, and in the $300 range per member per month for oncology care management as well. All of those are high intensity. People are already engaging those individuals, but when you augment them with the additional insights and the power to better connect, you get better adherence, better outcomes, and better compliance, and that translates to better outcomes for patients and a whole lot of cost savings.
All right, thank you. And staying with you, what are 2 or 3 steps that plans and providers should be taking now to achieve the same kind of successes you just talked about?
So, we clearly are advocates for bringing the best technology that's out there to help your members and patients today, and really moving beyond prescriptive analytics to AI-driven prescriptive analytics that understand what the next best action is for those patients. Begin matching your programs to your members' needs. Maybe you need a food as medicine program, maybe you don't, maybe you need online or telebehavioral health. Maybe that's not what's driving the risk in your population. And then finally, really measuring if you're maximizing your outcomes and identifying, where you have room for improvement and where you can, bring an AI asset to really benefit your members, your patients, and your business.
All right, and John Chowalter, would you like to add anything?
Yeah, first, thanks, and I'll make this quick. We're closing quickly here. The first thing is get educated. There's a lot of marketing out there, and you need to wade through the noise to see what's really working. And hopefully in the process of this conversation, we've emphasized predictive analytics is falling short. And you want to do something, find a solution that's going beyond predictive analytics. So get educated. Secondly, start with your most useful use case. So that use case you should easily be able to define a problem statement around that use case. And secondly, it should be aligning with strategy so you can align internal resources and executive sponsorship for it. So those are the two things I would suggest.
Great. Thank you for those insights. We have a couple of minutes left, so I'd like to move on to our Q&A with the audience. As a reminder, if you have not submitted your question, please do so now in the Q&A widget. And if we run out of time, we'll answer questions later via email. So it looks like our first question is, how should organizations use AI and social determinants of health without introducing more inequity?
So you really do have to concentrate on using the right techniques and very holistic techniques. So Dr. Felfeld and I were co-authors on a paper published in January demonstrating that when you use the right techniques and the right breadth of social determinants of health, you are able to accurately understand the risk for utilization, even without clinical risk factors or clinical understanding. That is not based upon a lot of the bias of other scores. The ethnicity, race plays very, very low in that understanding. Gender plays very low in that understanding. Age does certainly play a role in understanding that risk, but it is, in these techniques, a lot less of a factor than in some other predictive scores. So in order to do it, you have to do it right, and you have to use the right techniques, and you need to be working with people that are checking that and are ensuring that there isn't bias based into how they're determining risk and action, and that's built in and part and parcel to either your partners or your team's efforts around using AI. It has to be checked on an ongoing basis. You can't just assume you did it right.
Thank you. And our next question is, for clinicians on the front line, how is this changing the way they interact with patients?
Sean or Holly, you want to take that one?
Yeah, I was going to see if Holly, if you wanted to, but certainly we're
Sure.
seeing. I'll give a quick answer that it's changing how they think about a patient. So doing the usual things the usual way, and patients are still overlooked. And I don't have time for more examples, but they're legion. When we think about a patient just a little differently, it changes what I do for them, and it's changing the outcome. So when clinicians see that medicine is not as intuitive around our patients as we think it is, then we use these insights to help us think differently about them.
Yeah, I would just second that. I think that we're using the analytics. A lot of the care that we do is telephonic, and the AI analytics are giving us a picture of the patient that we didn't have before, is how my care navigators say. And that's really, again, helped them take care of the patients a lot better.
Thanks. And that's all the time we have for today. I want to thank Holly, John, and John for sharing their insights, and say a special thank you to Javion for making today's webinar possible. We'll be sending out the on-demand presentation in about 24 hours, so you can reference this webinar or share it with colleagues. This concludes today's event. Thanks, and have a great day.